Welcome. This is Module 6. Up to this point, the examples I've been showing you have been relatively clear cases of glaucomatous damage. In this module, we're going to confront the fact that things aren't always simple. There are artifacts, there are false positives, there are false negatives, and other diseases can affect the interpretation of the OCT. So let's start with the image on the screen here. I'm going to ask you, what does this OCT show, or why does this OCT show abnormal regions? So let's blow it up. You can see the dark red here on the retinal nerve fiber layer probability map. What's going on there? You can see over here, where I just placed the arrow, that the thickness goes down to 0. That's almost a sure sign that this is a segmentation error. And there it is, if we blow that up, you can see here that all of a sudden the contrast has changed. This is probably retinal nerve fiber layer here. I can identify this because here's the internuclear layer, so this must be ganglion cells in an plexiform layer. This is probably ganglion cell layer here that's dark. And all of this here is retinal nerve fiber layer. But because the contrast is poor, the segmentation is confused, and you're getting these defects. You see these defects, it's not uncommon in the nasal part of the scan. All right, so also you can see it here, which corresponds to this blue arrow here, and again, segmentation error. All right, what about that? I mean, that looks like a glaucomatous or optic neuropathy, at least arcuate, doesn't it? Well, let's take a close look. Where is that? Well, that is right there. Well, it's going into the red, yeah. But the visual field is clean. And I can tell you that this is a normal eye. Well, where should we see the defect? We can put the model up here. So the defect, let's put the model there. So we would expect to see this here showing up on here, and nothing's here. So what's going on? This patient does not have an arcuate defect. So the answer is it's due to the placement of the blood vessels. So a number of years ago, almost 10 years ago, Brad Fortune and I and colleagues did a study where we asked about the influence of blood vessels on retinal nerve fiber layer thickness. In particular, the peaks of the circumpapillary retinal nerve fiber layer thickness plot, that is this plot right here, typically coincide with the locations of the major blood vessels on the temporal half of the disc. So let me dissect that slowly. This was when we did the study, this was actually the original time domain machine, I believe. So this is all in T-SNP plot. So we marked the locations by hand of the superior vein, the major superior vein, the major superior artery, right? And then we marked the peak of the superior peak here of the retinal nerve fiber layer profile, and that's where it falls. By the way, the dashed line here is the average of normals. Did the same thing for the inferior temporal artery and vein, and the inferior peak, and that's where it fell. Another example, peak in white, vein and artery in blue and red. You can see the good agreement. In fact, we had 16 healthy eyes here, and all but 3 showed perfect agreement. So you can see the perfect agreement here, indicated by the overlap of the 3 circles. These 3 here, the circle, meaning the peak didn't quite coincide, but actually if you looked at all 3, they had the following pattern. Let's take this one here. So, that's the peak we labeled. That's where the vessels are, where this cross is. Right. So you can see it's close, right there. Okay, now there are 2 reasons why there's this good agreement between the peak of the retinal nerve fiber layer thickness around the disc and the location of the vessels. First of all, the blood vessels actually contribute to the thickness. So part of what you're measuring here is blood vessel thickness. And then second, they develop together. So in general, the arcuates that you see, the thick retinal nerve fiber layer arcuates that you see, track the blood vessels. All right, so what's going on and how do you detect this? Well, to avoid false positives, which is sometimes called red disease, this was coined by the originally by skeptics of the OCT. So to avoid false positives due to variation in the location of blood vessels, what you want to do is look carefully at the location of blood vessels. So on this report, we have these thin red lines that you may have noticed. This is the average location of the midpoint between the superior temporal vein and artery. And this is the actual location. You can tell of the vein and artery. You can tell by the shadows here. And you can see the peak is lining up with the shadow. And it's some distance from where the average of normals would be. And same thing over here. This is the average location of the inferior vein and artery. This is, you can see them, the shadows for those two vessels here in this patient. And again, lines up with the peak here. So a typical healthy control has retinal nerve fiber layer thickness that tracks the vessels. Let's make this transparent so you can see it more clearly. So that's typical. This patient here does not have an arcuate defect. This is due to a more central location of the temporal veins and arteries. And this is not atypical, as in it is typical, of high myopes. Right? So here's the fundus photo for this eye. You can see these vessels are coming off more temporally, and the thickness corresponds to them. Again, let's make that transparent. Okay, point number 2. Variations in the anatomy of the fovea can affect retinal ganglion cell probability plots. So some people have relatively shallow foveas, some people have relatively deep ones, some people have relatively narrow foveas, some have relatively wide, and this will all affect the thickness and probability plots. We just published a paper in TVST on this problem where we identified the false positives, that is artifacts, due to normal variations of fovea morphology. So we defined so we took a group of healthy individuals that we knew did not have optic neuropathy because they had all the usual tests. And so this is a healthy eye. And you can see on the probability map that there's a circular region that looks abnormal. Remember, dark red is 0.1%. So we defined a circumfoveal artifact as an abnormal region that is at least 1%, which would be red, largely within the central 4 degrees. So this blue circle has a radius of 4 degrees. All right, so here are 4 examples. And in fact, out of 126 healthy controls that met our criteria for circumfoveal artifacts, almost 10% of them had some kind of an indication of this artifact. And so that the inclusion is it had to fall within the circle, and it had to include both the upper and lower, or superior and inferior retina. So the advice here is if an abnormal region is circular, or part of a circle, and close, or part of an annulus, I guess technically, and close to fixation, is almost certainly not due to glaucomatous damage. But you want to check the rest of the report for consistency. So here's an eye here with an apparently abnormal region. You can see it in the retinal ganglion cell plot. You can also see it up here in the retinal nerve fiber layer plot, which can also happen quite often. So it's clearly an artifact in this case, but you always want to check the consistency with the rest of the report. So this section here looks absolutely normal. So on the other hand, this eye is troublesome. So we have this splotch here, but notice that it's outside of the 4-degree circle, and it respects the midline. Right. And you can see the chunk out of the retinal ganglion cell here. You can see some abnormalities here that are consistent with it. And you can also see the dip in the retinal nerve fibrillary. So that's what I mean by making sure everything is consistent. This is real. This is not an artifact. And it's in the macula. All right, so you want to check the consistency with the rest of the report and share, as well as the shape and location of the abnormal region. Excuse me. Okay, so it's yes, this is abnormal. Okay. All right, guess why the next OCT appears abnormal? So that looks pretty bad, right? But I've already told you to be aware of the nasal region. You often have artifact problems. And sure enough, there it is. If you look up here, you can see the algorithm's having trouble. And here. And here. And here. If it goes to 0, it's almost certainly an algorithm problem or segmentation problem. So this is a segmentation failure causing this artifact here. So what's going on with this eye? What's the cause? Well, this looks very funny. And I'll tell you, you see this kind of a funny pattern and you think epiretinal membrane. So this is suggesting epiretinal membrane to me. You can see this doesn't make sense. If we took and looked at the B scan through this just to check it, sure enough, there's the epiretinal membrane. So the arrow is about there. And that's, we take a B scan right through the fovea, and this is done with a higher resolution B scan. You can see why you often want to take a look at the B scan through the fovea. You can see the clear epiretinal membrane problem this eye has. Those arrows, this arrow here is in the same position as that arrow there. Okay, so it's easy to identify epiretinal membranes on en face slab images. So let's blow this up. This is an en face slab image, and all of this stuff here is all epiretinal membrane. Let's take this here and zoom in and take a look at a B scan here. That's what it looks like. So you can see why, if I tell you how this image is formed, you'll see why it does such a great job at picking up epiretinal membranes. So the way we get these en face images is we take the segmentation from the machine of the inner limiting membrane vitreous, and then we average a region, in this case 50 microns below that. So any break in the retinal nerve fiber layer or any break between the epiretinal membrane and the retinal nerve fiber layer will show up as dark. So in this particular case, at least some of the visual field abnormalities might be due to the epiretinal membrane damage to the retinal nerve fiber layer, because you can actually see damage is taking place here. Okay, so point number 3, epiretinal membranes can affect all elements of the report. So in this case, all of these elements here were affected by the epiretinal membrane. Advice: if the thickness plot looks weird, suspect an epiretinal membrane. And then check the B scans of the cube scan to confirm. And as I've said, we routinely obtain and examine horizontal line scans through the fovea. 3, en face images are useful and are available on most machines. All right, point number 4. Guess why this OCT appears abnormal. So what, oops, excuse me. What is going on here? Well, here's the disc for that patient. The glaucoma specialist in the city disagreed. Some say normal. Some said high myopia was the problem. Some said optic nerve drusen. So here's the defect. You can see it. There is something going on near fixation here. It's -27. So that looks like that's real. And if you look at the ganglion cell plot, there it is. Something's missing. There it is on the probability map. There it is on the retinal nerve fiber layer map. So it's real. Is it glaucoma though? Subtle, deep depression there. So is optic neuropathy present, and is it consistent with glaucoma? Well, the 10-2 first of all agrees. So again, if we circle these points here and then circle the equivalent region here, we would get this. So you can see that the fields are agreeing. But the pattern does not look like optic nerve damage, at least on the 10-2. So sometimes you need to look at the scan, sometimes you have to go to the instrument. So here's a line scan, a B scan through the fovea from the cube scan. So you just go to the instrument and take a look. That looks pretty good. Now let's put a line, look at the line scan through here. That's not the fovea. That's outside the fovea. Now we go a little bit lower, and that's what we get. And here's a 3D rendition. So this is some kind of a defect, perhaps of a vitelliform macular detachment of the fovea that's actually invading into the ganglion cell and retinal nerve fiber layer. So it is a problem. It is a retinal problem that's masquerading as optic nerve disease. So that's the fourth point. You've got to watch for retinal problems that masquerade as optic nerve disease. So the advice, always ask, does everything fit or agree? We routinely obtain and examine horizontal line scans through the fovea, and when in doubt, look at the B scans. So in this case here, a line scan through here told you what the story was. All right, point number 5. There are other optic neuropathies that can be confused as glaucoma. So the most common one is non-arteritic ION, or I'll just refer to it as ION, right? So here's a study that we presented at ARVO last year in which we collected patients that had ION and then matched them as closely as we could with patients that had glaucoma based on visual fields. So you can see there's an inferior visual field here in the ION patient. There's an inferior visual field here in the glaucoma patient. You can see the thinning here in the superior region invading into the macula. And you can see thinning here in about the same place. So to distinguish between these two diseases, and I have to say it's not uncommon for patients with ION to carry a diagnosis that is not correct of glaucoma. So as you know, you want to look for a pale rim on the disc photo, which is characteristic of ION, a crowded disc as opposed to clear cupping, history, sudden onset, etc. And there are also OCT signs that we're working on and others are working on. We think that the lamina cribrosa is thicker than in glaucoma for equivalent field losses. And it may be, we've had some success in distinguishing between ION and glaucoma by looking at the ratio of the BMO minimum moon width to circumpapillary retinal nerve fiber layer thickness. That's a technical point that may be lost on some of you, but not important for now. All right, what about this? Is this patient glaucoma, right? Well, notice that the field is worse near the disc than in the nasal region. That is not typical of glaucoma. Notice that you've got thinning here throughout the superior region. And notice what's happening here. There's no rim. There's no rim here. So what this is a superior segmental optic hyperplasia. This patient was born with this defect. And again, these patients, for whatever reason, all of a sudden discover this blind spot later in life, they go to an ophthalmologist and are often given the diagnosis of glaucoma. So you want to look for a missing rim on a disc photo. These patients typically have mothers who had diabetics during gestation. And again, possible OCT signs, not critical for this lecture, but if you're looking towards future use of OCT, again, the lamina cribrosa is thicker than in glaucoma. Okay, so how do we distinguish ION from segmental optic plasia from glaucoma? You seldom see the following pattern in glaucoma. So here's two eyes, one with ION, one with superior segmental optic hyperplasia. What are some rules we can use to try to identify the fact that these are not glaucoma? Well, first of all, visual field is worse at discs. You know, if you have a situation where the visual field is worse at the disc here than it is in the nasal region, that is seldom glaucoma, right? Second, the inferior half of the retinal nerve fibrillary thickness plot is completely normal. Normal, usually down somewhat in glaucoma. Third, the superior half of the retinal nerve fibrillary thickness plot is uniformly and markedly thin. So uniformly and markedly thinned, uniformly and markedly thinned. That can happen in glaucoma. Often you'll have some kind of local variation in loss. Okay, so here's ION versus glaucoma, just to make the points. Notice that in this particular case here, the defect is not worse at the disc compared to ION. This is thickness is down compared to ION. And this thickness here has some variation in it, although I'm not going to push that point. Okay, point number 6, normal variation. So here's an eye, that is clearly healthy. Everything looks normal. But you don't expect all healthy control eyes to look like this. And let me give you some examples that have been provided to me by courtesy of my colleague, Dr. Gus De Moreas. So in this particular case here, you have this defect. What is it due to? Already gave you the answer. Is it real? This was a healthy eye, right? Well, if you look here, that's where the vessels usually are. In this particular patient, the vessels are here, creating this apparent artifact because of thinning right here. Technically right there. What about this? There's some funny stuff going on here. Well, glaucoma is not going to be near the center of the disc like that, so you can just dismiss that right away, right? But that's also due to anatomical differences. And this eye, as you might expect, has a totally normal visual field. Okay, what about this here, right? Well, again, I already gave you the answer to this. This is undoubtedly variation in foveal anatomy. It's more or less within the central 4 degrees, and it's circular. Here's another one. This is probably the hardest to identify. Notice this is a healthy control. Notice it's down everywhere, more or less uniformly. This eye just happens to be at the lower limit of normal. And it produces these defects that look like scattered artifacts and other scattered arcuates rather, and other kind of artifacts. So, random abnormal regions probably due to lower limit of retinal ganglion cell and retinal nerve fibrillary. But in a patient like this, you really have to confirm that with a visual field. So these patients are tough to dismiss strictly based on OCT. Notice there's a little something going on here. What's that? Right? Is that real? Well, there it is. Right? If you blow it up, you can see it's a segmentation error that's producing that and that segmentation error. Okay. So what do you think about this eye? Well, first of all, the blood vessels. Now look at the blood vessels are probably causing this, right? Because there's the blood vessel, and there's the peak. Remember, this is flipped vertically into, flipped along the horizontal meridian for field view. So that is that. So that's blood vessel. What about this? Well, again, that's not glaucomatous. You don't get damage like that so close to the fovea. So what is causing that? Excuse me. What is causing it? Well, in this particular case, it's caused by the fact that the foveal center here is well below the disc. So it's creating this. There may be ways to correct this in the future. Okay, so things aren't always simple. You have to watch out for artifacts, false positives, false negatives, and other diseases. And thank you for listening. That's the end of Module 6, and I hope you'll join me for Module 7.